Ahi Marie, I'm Heather. I am a doctoral candidate. I'm an oncology clinical nurse specialist and an educator here. So I'm conducting research which explores the assisted dying service experiences of nurse practitioners and medical practitioners in Aotearoa, New Zealand. Today I'll just be sharing some key findings from a comprehensive literature review which has informed the early stages of my research, and I have no conflicts of interest to declare. So in this I'm going to talk about what is assisted dying, how did it come to be, where does it belong in New Zealand, what does the literature say, and is there a need for more research? So on the right side of this screen is the eligibility criteria for assisted dying, or mate whakahuru, which means to die in a warm and comforting manner. The controversial aspects of the eligibility criteria could be a presentation in themselves, so I won't talk about that. But for us, as a broad definition, it's the intentional hastening of death at the explicit, voluntary, informed request of a competent individual. So there are several different terms that are used interchangeably in the literature. Some states in the US will use physician-assisted suicide, Canada will use medical assistance in dying, and Australia uses voluntary assisted dying. So physician-assisted suicide is when a doctor provides a prescription to a terminally ill, mentally competent patient for a lethal dose of a medication, and that patient will then self-administer voluntarily that medication to end their own life. Euthanasia is slightly different, but broadly speaking that's when there's a third party involved in the hastening of death, and for us here that would be a nurse practitioner or a medical practitioner. So I won't talk too much about this, but this is what the care pathway looks like for a person seeking an assisted death. So there'll be 2 eligibility assessments by medical practitioners. If there's a question of competence, then a psychiatrist will be involved as well. A decision is then made. If they're eligible, they would then plan and have an assisted death. So how did it come to be? So ACT MP David Seymour, he entered the end-of-life choice bill into the members' ballot. As you'll see on the slide, it passed the first 3 readings. Within Parliament, though, it became more and more controversial. With each reading, the number of opposing votes went up. And the public interest during this time was also unprecedented, with the Justice Committee receiving over 39,000 submissions from interested groups and individuals, so much so that 4 subcommittees were formed to make sure there was adequate coverage of all those voices. And then, of course, we had the public referendum in October 2020 with a 65% majority vote. The Assisted Dying Act was implemented just over a year later. Prior to this, there were 4 attempts to address assisted dying in New Zealand Parliament between 1995 and 2015. So where does it belong? Well, in April 2021, the government announced that we would have a unified health system, and that signified the end of the postcode lottery, suggesting a more equitable health system. November 2021, the End of Life Choice Act was implemented, and the Ministry of Health were responsible for overseeing that. In July 2022, Paeora, the Healthy Futures Act, came into effect, and that established these 3 entities that you can see on the screen. Paeora is the legislative foundation for the health system in New Zealand. In March 2023, the operational aspect of assisted dying was transferred from the Ministry of Health over to Health New Zealand. And then in November 2023, the government announced their intention to disestablish Te Aka Whaiora, which is the Māori Health Authority. The disestablishment of Te Aka Whaiora in 2024 was very controversial because it dismantled a central part of the Paeora reforms, which were designed to address Māori health inequities and uphold te tiriti. This is really relevant for my research on assisted dying because it highlights ongoing concerns about whether the current system can ensure equitable and accessible end-of-life care for all, particularly for Māori. Assisted dying does not sit in isolation. It's shaped by how the health system is funded, how it's staffed, how it's structured, and how it's governed, and these are all outcomes of Paeora. So the only graph of the presentation. So the blue columns are the number of assisted deaths that have been requested, and this is going year on year. The orange is the number of assisted deaths that have been carried out, and the green is the number of practitioners on the SCENS list. That's the support and consultation for end of life in New Zealand. So when you look at quarterly data rather than annual, you'll see the number of practitioners on that list has fluctuated quite a bit. Also important to know that some practitioners on that list might hold more than just one role. So with this numbers increasing of people seeking assisted deaths, but not so much increasing in the number of practitioners providing it, it adds to the growing concerns of equity, particularly regional equity, and of service capacity. On this slide here, we have a conceptual framework of health service accessibility, which defines access as the opportunity to reach and obtain healthcare services when needed. So it highlights the dynamic interaction between the characteristics of health services, which is what you can see across the top of the screen, and the ability of individuals seeking care, which you can see across the bottom. My focus has been on the service side. Particularly for this literature review, I've looked at acceptability, which considers how culturally and socially acceptable the service is. So I employed this search strategy here to conduct a literature review across 6 databases and my findings. So theme 1 was the motivational basis for participation. So this theme talked about the reasons why health practitioners felt confident and comfortable to provide assisted dying. They felt they were respecting the rights and the autonomy of their patients by honouring their wishes. They also spoke about their own suffering, which had came about from bearing witness to suffering or crisis within their patients, and they felt relieved of their own suffering when their patients had the option of an assisted death. They also felt that having the option of an assisted death was really empowering for their patients, whether or not they carried that out. Theme 2, I've called that cautious practice, and that theme describes some of the aspects of assisted dying which practitioners felt a bit hesitant about or a bit cautious. So 1, they spoke about the lack of dedicated training or education and the workload and administrative burden that accompanied assisted dying service provision. Not so much that that's what put them off, but they felt that was a factor to consider because the amount of meticulous planning that went into providing a smooth assisted death was so time-consuming that practitioners didn't always feel confident that they'd be able to maintain that standard of care. So for some, it felt easier to not provide the service at all than to introduce the possibility of differing standards of care. There was also the emotional impact on those providing assisted dying, and that's not just in the here and the now, it's the future unknown psychological impact as well. And lastly, for theme 2, health practitioners spoke about the fear of being known as an assisted dying provider. Theme 3 talks about some aspects of providing assisted dying that sat most uncomfortably with health practitioners. One aspect is when patients are due to have their assisted death, they need to be competent to consent on that day. Sometimes that means that medications which might cloud somebody's judgment would be withheld. So patients might then experience pain or nausea, other symptoms which would mean that they were suffering. For some health practitioners, that was incompatible with the Code of Ethics or with their sworn Declaration of Geneva. Another argument, which came in the literature from pharmacists, so not who I was looking at, but still very relevant, is the doctrine of double effect. So in medicine, prescribers can give medications with well-intended effects, and there are some negative secondary effects, of which the practitioners are not held to account on the basis of intentionality. With assisted dying, the intention is very clear. So for some, they felt that that was a breach of the doctrine of double effect. There are also legal restrictions around initiating conversations about assisted dying with patients. This is done to avoid the potential of coercion. For some health practitioners, particularly those working in palliative care, they felt that this was inauthentic due to the inability to be open and honest of all options available to their patients. Some health practitioners also spoke about feeling uncomfortable sharing their views in case they were met with hostility. And this was particularly true if they were in the presence of somebody in a position of authority, like a manager or another leader. And then some felt that just generally having assisted dying in society placed us metaphorically at the top of a slippery slope, with the biggest concern being around the loosening of the eligibility criteria. And theme 4 here, the motives for non-participation and conscientious objection. What came through in the literature most strongly was the role of religion. So Christianity, Hinduism and Buddhism were considered largely incompatible with assisted dying. Other non-religious reasons for non-participation included cultural beliefs, particularly some Asian cultures spoke about a fighting spirit that was deeply ingrained in their cultural identity, and that to have an assisted death or to support someone else's assisted death was seen as weak and giving up. Lastly, there was a belief that our inevitable death is at the behest of destiny, not specific to any religious figure or belief, but that there's something exists which is bigger than us, and that it's not our role to interfere with a natural death. So the gaps in the literature, because it's still quite new, we don't really know what the experiences of New Zealand health practitioners who are providers of the assisted dying service, and we don't know about the experiences of those practitioners who are choosing not to provide, which is what I'm researching, with the overall question of is the assisted dying service aligning with Pai Ora as it should? Record time. Thank you.